Rajiv sir, am I audible?
Uh, of course, you are audible. Fine.
Fine, fine. Okay. Hello, sir.
Hello, how are you?
I'm fine. How are you, sir?
Great. So this is your
Yes,
debut to our DigiConnect webinar. Yes, great.
yes. Debut to the, the motherland. I'm basically from Haryana
Yes.
and worked actually in Nancy
Yeah.
for 1 year.
Yeah.
Yeah, and now settled here.
Great.
So yes, the debut thing for my MICA organization.
Okay. Yeah. India won.
Yes. Okay, Dr. Ramanjeet is also here.
Yeah. Hi, good evening, everybody.
Good
Hi,
evening, good evening, sir. Good evening, sir. Must be cold there, Christmas evening. So you're on mute. Dr. Ramanjeet,
It is very cold, but little better than the climate a week back. It has increased by 2 degrees. Earlier, the lowest was 3-4 degrees, but now it's 7-8, manageable.
Mysore, we are at very pleasant area actually. Mysore is very good. No
You,
winters, no summers.
where are you exactly?
I'm at Mysore. I'm at Mysore.
Okay, great. So Bangalore,
Basically from
Pune,
Delhi,
and
but now
Mysore,
I'm
I
at
think
Mysore.
three places have very neutral climate. So,
Yes.
great.
Just
So we
wait
can
for
proceed.
participants. Shall we
Dr.
start?
Parul, 6:30. It's past 6:30 now.
Yes, it's 6:31.
Yeah.
So shall we start, sir?
Yes, sure. Go ahead.
Okay. So a very good evening to everyone, and a warm welcome to all you in this very cold evening of Christmas. And I'm Dr. Parul, product of PGMS Rohtak, and now serving as a senior medical officer and OHP at TVS Motors Mysore plant. And I'll be moderating this session. So this is our issue number 84 of DigiConnect webinar. And I must say and want to congratulate that this is a very, informative platform for regular updates. And for sure, it is team effort of AUHT. And thank you for giving me opportunity to moderate this session. So I'll just give quick instructions, not wasting much of the time. There will be two sessions. One will be headed by our speaker, Dr. Rajiv Kumar Jain, and another by Dr. Ramanjeet. I request all of you to please keep yourself on mute. Kindly not interrupt speakers in between. We'll have question answer sessions in the end. And if any query and any question, you can put it in question and answer box or in chat box. So, yeah, please keep yourself mute. That's most important to avoid unavoidable noise behind. So, let me just introduce our own Dr. Rajiv Kumar Jain ji. He will be taking our first session. So, he is Senior Consultant, Health, Indian Railways, New Delhi. 40 years of experience in health and hospital administration. Fellow Award of Indian Public Health Association, Fellow Award of Association of Environmental and Occupational Health Delhi, published and presented many more, almost 145 scientific papers in national and international conferences, journals, and books. Fellowship and scholarship by WHO, National Institution of Health, NIH USA, Canadian Society of International Health, International Clinical Epidemiology Network, and International Society for Priorities in Healthcare. And he was my teacher when I was doing KSIH in Bangalore ICMR. So it's an honor to sit with you, sir, here and moderate this session. So I welcome you, sir. And sir will be updating us on latest updates and evolving scenario of COVID-19. So handing over to you, sir.
Thank you, Dr. Parul. I don't know how much I deserve the words that you've spoken, but all the same, let's get on with COVID-19 epidemiological updates on Saturday evening. And imagine, this is the 49th episode. When we started this COVID-19 epidemiological updates, I really did not expect that we'll be running such a long series of COVID-19 epidemiological updates. But here we are, and we are not even near the end of the pandemic. We are in the very much in the eye of the pandemic, very much in the center of the pandemic. And epidemiology as a science enables us to be more realistic, to prepare better, and to face the situation in a better manner. So for the next half an hour, we shall review the COVID-19 epidemiological situation, but today we will also address 3 additional issues as we go along. But before that, let's get an update from the World Health Organization in a video which will give you an overview of the current situation. Let's play the video before we get on to review the data.
Bienvenue à cette nouvelle conférence de presse.
It's frankly difficult to understand how a year since the first vaccines were administered, 3 in 4 health workers in Africa remain unvaccinated. While some countries are now rolling out blanket booster programs, only half of WHO's member states have been able to reach the target of vaccinating 40% of their populations by the end of the year because of distortions in global supply. Enough vaccines were administered globally this year that the 40% target could have been reached in every country by September if those vaccines had been distributed equitably through COVAX and Epid.
Comme vous le voyez, nous avons encore quelques problèmes de connexion.
We are encouraged that supply is improving. Today, COVAX shipped its 800 million vaccine doses. Half of those doses have been shipped in the past 3 months. Our projections show that supply should be sufficient to vaccinate the entire global adult population and to give boosters to high-risk populations by the first quarter of 2022. However, only later in 2022 will supply be sufficient for extensive use of boosters in all adults. So I call once again on countries and manufacturers to prioritize COVAX and Epid and to work together to support those who are furthest behind.
Arabe, chinois, plus portugais.
Today, the WHO Strategic Advisory Group of Experts on Immunization, or SAGE, is issuing an interim statement on booster doses. SAGE concluded that the focus of immunization must remain on decreasing deaths and severe disease, and expressed concern that blanket booster programs will exacerbate vaccine inequity. About 20% of all vaccine doses administered every day are currently being given as boosters or additional doses. Blanket booster programs are likely to prolong the pandemic rather than ending it by diverting supply to countries that already have high levels of vaccination coverage, giving the virus more opportunity to spread and mutate. It's important to remember that the vast majority of hospitalizations and deaths are in unvaccinated people, not unboosted people. And we must be very clear that the vaccines we have remain effective against both the Delta and Omicron variants.
The Omicron variant now out.
But I think this is a time of where the data is evolving. We're learning more and more. It's important that we do not conclude that vaccines are ineffective at this stage. We've said repeatedly, it's very unlikely that a vaccine will become completely ineffective clinically, because that's not how vaccines usually act. But obviously, we have to be driven by the data, and our recommendations will change accordingly based on the emerging evidence.
Please raise your hand. I call upon you, please.
There's a lot more to do. I do believe we're still in the middle of this pandemic, unfortunately, but I completely believe that we have the power to end it in 2022. So vaccine equity and getting the vaccines to those who need them most in all countries must be a priority for every single government, not just some. We need to also be able to use tools to drive transmission down, because if we don't, we will continue to see the virus change and the virus threaten us in ways that will bring us closer to the beginning rather than closer to the end.
I think we're very good. Thank you very much, Dr. Swaminathan.
What we are learning about Omicron is certainly we have this increased transmission, but the information on severity is still uncertain. We don't have that complete picture yet, and it is too early to conclude whether or not Omicron is less severe than Delta or is as severe as Delta. Now, we do have some data suggesting that rates of hospitalization are lower, some information that people who are hospitalized don't need as much oxygen or invasive ventilation. But again, we have not seen this variant circulate for long enough in populations around the world, certainly in vulnerable populations. We did learn some information this week that Omicron, as it enters older age groups, older people with Omicron tend to have more severe disease. That's unsurprising. We know people have died from Omicron. It's too early to conclude.
In Botswana on November 11.
We do know that people who are vaccinated have a much lower risk of developing severe disease and death to both Delta and Omicron. So we stress the importance of vaccination when it is your turn. Regardless of what information we do find out about Omicron and the different vaccines that are in use, it is better to be vaccinated than not. So if you hear anything from us today, please hear that and get vaccinated when it's your turn and fight like hell for vaccine equity for everybody else around the world.
Answer a few minutes ago about the fact that the tag.
So we are, as you heard, we are in the middle of the pandemic, and the center of the pandemic today is Omicron. And if we look at future, let's look at the model brought out by Institute of Health Metrics of US, where you can visualize through this model what is going to happen in the next 3 months. I will take you to that visual where you can understand, according to this updated COVID-19 visual, we project 3 billion infections over the next 3 months globally. 3 billion. Omicron is rapidly spreading around the world since October 8. Let's look at the visual of the model. Secretary, please play that visual of the model. We are seeing the data at the top, and we are seeing how Omicron is spreading. And Omicron is going to be the most dominant strain all across the world within the next 3 months. Just keep an eye on the date at the top. And how from South Africa, the whole world is turning from purple to deep red. Just in 3 months. So let's understand the situation better. And let's look at the situation, how India is prepared, and how India's infrastructure is prepared to handle this wave of Omicron that is going to eat us in the next months, next 3-4 months. And we shall study this in this 5 slides of Omicron cases up, night curfewing, and lockdowns next, question mark. Next slide, please. The first aspect is Omicron likely to spread faster in India? The Union Health Ministry has said that there are initial signs of a surge in COVID-19 cases, as well as increased detection of Omicron in different parts of the country. The World Health Organization has already said that there is consistent evidence about Omicron spreading significantly faster than the Delta variant. It warned that social mixing over the holiday period could be dangerous. It is likely that people who have been vaccinated or have recovered from COVID-19 could be infected or reinfected. India still has a significant non-vaccinated population, which may cause a faster spread in India. Second aspect is India ready with the medical infrastructure? The government is readying for a third wave. As the management of COVID-19 patients needs isolation facilities, the number of isolation beds have been ramped up from 10,180 before the first lockdown to 18,03,266 as on 3rd August 2021. Similarly, the number of ICU beds have shot up from 2,168 pre-COVID to 1,24,598. India has attempted to step up oxygen availability across states. As on date, 3,236 pressure swing adsorption, that is PSA plants, have been installed with a total commissioned oxygen capacity of 3,783 metric tons. Moreover, 1,14,000 oxygen concentrators are being provided to states under different packages. Let's look at the third aspect. What does the country's health statistics say? It is not a pretty picture. According to government data, India has 1.4 beds per 1,000 people, 1 doctor per 1,445 people, and 1.7 nurses per 1,000 people. According to Rural Health Infrastructure Statistics released by the Union Health Ministry, there is a shortfall of 6.8% in allopathic doctors at the primary health center as of March 2020. Let's look at the fourth aspect. Next slide, please. What measures have states announced? States have started monitoring and increased testing for Omicron cases. As per directions from the Union Health Ministry, all travelers coming from countries deemed at risk are being asked to mandatorily undergo testing on arrival through RT-PCR, followed by home quarantine for 7 days. A repeat RT-PCR test is done on the 8th day of arrival. 2% of the travelers from non-at-risk countries are tested at random. Those testing positive are subjected to whole genomic sequencing at certain laboratory. And the last aspect, the fifth aspect is there a possibility of a lockdown? There are chances India may reimpose curbs. The center appears concerned over the signs of a surge in infections. The Union Health Ministry on Tuesday asked states to impose night curfew coupled with strict regulation of large gathering. Christmas and New Year are around the corner, and large social gatherings could well become a super spreader. The ministry has urged states to impose curbs on the number of people who can attend marriages and funerals, restrict the number in offices, industries, and public transport. So that is the current situation at the moment. Let's look at another. Let's look at another aspect of the pandemic, the deaths, and where did the deaths occur in India during the pandemic? The poor faced more COVID deaths, suggests a study published in the Lancet's Infectious Disease Journal. The poor communities saw far more excess deaths during the COVID-19 pandemic than rich neighborhoods. Evidence from a new Chennai-based study shows. Taken with data from other parts of the country, the findings suggest that India's poor, particularly the elderly, may have disproportionately borne the burden of the pandemic's fatal impact. In a study published in the Lancet's Infectious Diseases Journal, early Thursday, researchers led by Ramanan Lakshminarayan of Princeton University looked at mortality data from the government civil registration system, that is CRS, alongside the census-based measures of affluence. Researchers from the universities of Berkeley and Chicago and top bureaucrats in Tamil Nadu were part of the study. Chennai recorded nearly 26,000 excess deaths between March 2020 and June 2021, or a 40% increase over deaths otherwise expected based on the pre-pandemic trend. The study said this implies more than 5 excess deaths per 1,000 people, and this was particularly higher for older age groups. The researchers mapped PIN codes death certificates with socioeconomic variables of affluence and deprivation to classify areas by socioeconomic status. Neighborhoods with lower socioeconomic status had substantially higher excess mortality. Belonging to a scheduled caste or a scheduled tribe was also a predictor of higher risk of mortality. Next slide, please. Let's look at the graph. On the left, you're finding mortality in Chennai significantly during the pandemic, especially among older age groups. This is showing expected deaths versus observed deaths by age groups, Chennai from March 2020 to June 2021. The gray dot is expected deaths and red dot is the observed deaths. Excess mortality per 1,000 people is shown on the right side of the figure. And you look at the bottom, 80 plus population, 96.9 excess mortality per 1,000 people. 70 to 79 age group, 39.7 excess mortality. 60 to 69 age group, 21.0 excess mortality. So the higher age group bore the brunt of the mortality. On the right side, you're seeing COVID-19 turned out to be more fatal in poor neighborhoods. The graph shows percent increase in excess mortality from March 2020 to June 2021 for various household types. The highest is in the crowded households. On-site latching 2.5. Lack on-site water 2.3. Lack electric lighting 1.8. Lack bank accounts 1.8. Dilapidated dwelling 1.6. And dense areas 1.3. And lack key index assets 1.1.
I think there's some network issue with Dr. Rajiv's net.
Ma'am, we shall wait for 5-10 seconds, ma'am. He will join. He will join.
Yes, yes.
Sorry, the connection was lost. So now it's on track. Let's have the next slide, please. Yes. We compare the first versus the second wave. Neighborhoods with low socioeconomic status had 0.7 to 2.8% higher excess mortality, possibly linked to the pandemic for each standard deviation increase in measures of community disadvantage, the study found. But the paper also found that excess mortality was much more during the second wave. Mortality during the first lockdown period was lower than normal, driven by a substantial decline in deaths among men in their 20s. This excess mortality increased a little in the men in the first wave, but reached its highest in the second wave. Poor neighborhoods did not consistently report higher excess mortality than rich neighborhoods in the first wave, indicating a lesser impact in 2020. But this relationship was clearly established in the second wave. V. Chandramohan, Principal Secretary to the Government of Tamil Nadu, who is also a doctor and one of the co-authors of the paper, said this was one of the first studies to look at demographic and other details rather than excess deaths alone. Increase in mortality and the undercount was primarily driven by the second wave is visible on the data that you are seeing on the right side of this slide. Crowded households, 6.3 is the rise in mortality rate in percent for various household types. Dense areas 3.7, non-permanent housing 4.5, dilapidated dwelling 4.1, lack on-site water 7, and practiced open defecation 3.6, and lack on-site latrine 6.4, lack electric lighting 5.3. So that is the scale. And now you can see the granular data. Let's look at the next slide, please. This shows the gross undercount. Tamil Nadu is likely among the states with the lowest death undercounts. If you look at the bar diagram on the left, this shows ratio of excess registered deaths to confirmed COVID deaths in the second wave in Madhya Pradesh, Andhra Pradesh, Odisha, Haryana, Gujarat, Tamil Nadu, and Kerala. Chennai's excess mortality ratio is unlikely to be representative of the national average. Rather, it may even be a much more benign version of the national picture. The CRS-based estimates of excess deaths collected so far show that states such as Madhya Pradesh and Andhra Pradesh are likely to have missed far more COVID-related deaths than Tamil Nadu or Kerala. It would appear that states such as Kerala or Tamil Nadu with better state capacity had lower undercount ratios than states such as Madhya Pradesh and Andhra Pradesh. Prabhat Jha, founding director of the Toronto-based Center for Global Health Research, said, Jha and his colleagues have collated estimates of excess mortality from the CRS and from the National Health Mission's Health Management Information System to suggest in a preprint paper that India's COVID mortality may be 7 to 8 times the official estimates. And this is what the science is reflecting on. Next slide, please. Parallels from Mumbai. Studies from Mumbai suggest more missed deaths in poor areas. The figure on the right side is showing the infection rate in percentage in slums 69% and in non-slum 43%. On the right side is undercount factor of deaths. In slums it is 3.4 and non-slums it is 1.3. Undercount factor of deaths refers to the number of times the excess deaths is as compared to the recorded COVID-19 deaths. The trend showing higher burden of the pandemic on the poor has parallels from studies in Mumbai. Murad Banerjee, a mathematician at the University of Middlesex, looked at the city's official COVID-19 fatality and seroprevalence data and all-cause mortality data and found a substantially higher spread of COVID-19 infection in Mumbai's slums than in non-slum areas in 2020. While excess mortality was not substantially different in the two cases, Banerjee found that officially recorded COVID deaths were disproportionately low in slums, implying far greater undercounting of deaths. The Chennai study shows correlation between deaths and affluence, but much more work needs to be done to establish the causal factors. Mohan said, wards are not homogeneous, and an area usually has both rich and poor households. It will take more granular work to conclusively establish why we are seeing this pattern. So this shows much more research needs to be done on this vital aspect of pandemic deaths. Next aspect, the next issue we're going to study is the surge in cases and vaccinations. Where are we? Over 415, as on date, 415 cases of Omicron variant have so far been detected in India. However, unlike the surge in cases in South Africa after the detection of the more transmissible variant, there is no surge in India currently. Except India's population is about 20 times that of South Africa. Is it the case that there are local outbreaks happening in India? More importantly, how protected is India should an outbreak happen? Apart from transmissibility, the Omicron virus is also proving to be more resistant to vaccines than its predecessor. This means at least 2 doses of COVID-19 vaccine, if not an additional booster, might turn out to be a necessary tool in keeping the share of severe cases low and reducing hospitalization if there is an outbreak. We shall see 4 charts to understand how India is doing on these fronts. Next slide, please. The first, Currently, there is no surge in cases, and positivity rates, even at the district level, is reasonably under control. Districts where COVID-19 cases have increased in both fortnights of past month, the weekly average of daily COVID-19 cases was 7,117 on December 18, down from 8,673 on December 6, and 8,048 on December 12, and the lowest since the week ended May 31, 2020. There is therefore no surge in cases. However, as India is a large country, a rise in cases in one place can be offset by a larger decline in another. District data compiled by How India Lives shows that even such local outbreaks are not taking place currently. The growth rate of cases at the district level between 3 dates, each 2 weeks apart, between November 16 and November 30, and between November 13 and December 14 is analyzed. The weekly average of cases grew in both fortnights for only 13 of the 707 districts for which data is available. Despite growth in cases over the past month, the 7-day average was less than 50 in all these 11 of the 13 districts. In Hyderabad and Bangalore, cases have grown and are more than 50. Last week's average was 78 cases in Hyderabad and 187 cases in Karnataka. Is the low number of cases because of low testing? Cumulative tests have indeed fallen since the peak of the second wave, but have not caused a high positivity rates. Positivity rates averaged 0.59% nationwide in the week ended December 15. The Health Ministry releases a list of districts with high weekly positivity rates. 25 districts had positivity rate above 5% in the week to December 15, and 15 of these were from Arunachal Pradesh, Mizoram, Nagaland, and Sikkim, where cases are declining in all the districts. 9 districts are from Kerala. In 3 of them, Pathanamthitta, Kannur, and Kottayam, cases have increased in the past fortnight by 2% to 10%, after declining around 40% to 50% the fortnight before. In Kolkata, where positivity rate was 5.9%, cases have declined 22% in the past fortnight. Next slide, please. Second is, the second dose coverage is still low in about a third of the districts. India is, however, ill-prepared in case there is a surge. Early studies suggest that Omicron variant might be more resistant to the vaccines. Late last week, the first real-world evidence arrived of how vaccine efficacy against symptomatic COVID-19 all but erodes in case of an infection with Omicron variant, suggesting that boosters might be needed for those who have received Covishield jabs. This makes for speeding up full vaccination all the more necessary. 36% districts, that is 229 of 628, are still lagging on this metric, with less than 50% adults fully vaccinated. Since official population projections are not available at the district level, HT has used the number of electors in the district at the time of 2019 Lok Sabha elections as a proxy for the adult population. A third of 45 plus age group, half of rural India is not fully vaccinated. COVID-19 vaccination for those at 45 years and above who are more vulnerable to severe disease and death started on April 1st, a month before those in the 18 to 45 years old age group began receiving the jabs. Those with comorbidities in the old age group were being jabbed even before April, yet 34% of the 45 plus age group is not yet fully vaccinated, according to the age-wise vaccination update of the Health Ministry on December 18. On the other hand, while there is only an 8 percentage point difference in first dose coverage between the older and the younger age groups, the gap in second dose coverage is wider at 17.2 percentage points. It means the young will also be vulnerable if Omicron proves to be more severe than its predecessors. The 45 plus age group needs full vaccination and possibly boosters because they are vulnerable to severe disease. Rural India, on the other hand, is vulnerable because it lacks health facilities. While scaling up health infrastructure is a time-consuming and expensive exercise, vaccinations, which have to be inevitably given to every person, can be a preemptive tool against catastrophe. However, this group is also not sufficiently covered with full vaccination. Only 55% of the population in rural districts is fully vaccinated, compared to 60% in the mixed districts and 73% in urban areas. Districts with share of rural population below 40% in the 2011 census are considered urban. Those with more than 60% rural population are considered rural, and the rest are considered mixed. While rural areas are indeed getting more doses per million population now than urban areas, this reversal has happened only in late October. Next slide, please. Third aspect is we can speed up to cover the vulnerable. On the right side, you are seeing the bar diagram where it is showing total doses administered every month. There is no reason why these vulnerable groups cannot be vaccinated at a faster rate. India administered over 236 million doses in September. In October and November, only 173 and 178 million doses were administered. While that speed in December so far looks to surpass the rate of the past 2 months, that is 135 million doses have been administered so far, it will be important to keep this rate up, possibly by reaching out to the elderly and those in the remote and rural areas. Next slide, please. So we have seen the three important aspects. We look at the epidemiological situation today. This picture is showing the districts with weekly positivity rate of more than 10%. And the week in this case is 18th of December to 24th of December. And these three districts are all in Mizoram: Champhai, Mamit, and Khazol. What you are seeing is the distribution of rapid antigen test versus RT-PCR, and all these districts you are seeing dominated by substantial rapid antigen tests, with 92, 97, 89% tests being rapid antigen tests. So what these Mizoram people need to do, they need to reverse this. Majority, that is more than 70%, should be RT-PCR tests. Let's look at the slide which shows the weekly positivity rate between 5% to 10%. And it shows 9 districts of Kerala. It shows 1 district of Manipur, and it shows 6 districts or 7 districts of Mizoram, 1 district of Sikkim, and 1 district of West Bengal, importantly Kolkata. And Sikkim, it is North District, where both in Sikkim and West Bengal, substantial testing is being done through RT-PCR. And yet the rate of positivity rate is 8% in Sikkim, and West Bengal, Kolkata is 5.47%, which shows active transmission in these areas. Kerala, Manipur, Mizoram, Sikkim, and West Bengal are having active transmission in these districts. And they need to ensure that active surveillance, testing, tracking methodology is used effectively on the ground in these districts. Next slide, please. Now we go to the Southeast Asia region. The declining trend in the number of weekly cases and deaths reported has continued in the Southeast Asia region. Over 86,000 new cases and over 2,400 new deaths were reported, decreases of 12% and 6%, respectively, as compared to the previous week. Only 2 countries reported an increase in weekly cases, that is Timor-Leste with 300% increase, and Sri Lanka. The highest number of cases, new cases, continue to be reported from India, 49,765 cases with 13% decrease, Thailand with 17% decrease, and Sri Lanka with 30% decrease. The highest number of new deaths also continue to be reported from India, that is 6% decrease, Thailand with 9% decrease, and Sri Lanka with 10% decrease. And you are seeing the entire graph of Southeast Asia pandemic, how it is going down, yet not touching the bottom. Next slide, please. Now we go to the world and look at the entire graph of the pandemic in the world. And what do we see? It is dominated with green. Green means Europe. And the world is into the 4th wave of the pandemic. If you look at the peaks, the colored peaks with yellow at the top, you're seeing the 4th peak, 4th wave at the moment globally in progress. Next slide, please. This is the newly reported and cumulative COVID-19 confirmed cases and deaths by WHO region. And you are seeing overall, though globally there has been 2% decrease in cases week on week, but there was 53% increase in Africa, 12% increase in Western Pacific, which was enabling neutralizing the decreases in other regions. That is, Europe showed 3% decrease, America's 10% decrease, Southeast Asia 12% decrease, and Eastern Mediterranean 12% decrease. In terms of deaths, week on week, there was 9% decrease overall in the world, but there was increase of deaths of 15% in Africa, and in other regions, there were decrease in the number of deaths week on week. Next slide, please. This is the graph of the pandemic of the WHO 6 regions, and what you are seeing the bottom blue graph of Africa is highest ever wave. That is the 4th wave. And Europe, it is the highest ever wave in Europe at the moment, the green one. The yellow one also is showing evolution of the new wave in the Americas. But you are also seeing a Western Pacific rise and initiation of the new wave coming up. But at the moment, Eastern Mediterranean region and Southeast Asia region are on the decline, and predictably, they are waiting for the next wave to come. Next slide, please. In this slide, the next slide, we are showing 6 countries each, and that they are the top 6 countries in this slide. United States of America, with the cases shown on the left top, total cumulative cases, you're seeing the upsurge. Upsurge means higher than ever in the past waves. India, of course, is showing a downslide. Brazil also showing a downslide, but United Kingdom showing the highest of the waves ever in the pandemic. Russian Federation is just had a high wave. Now it is going down. Turkey is also on the downslide. Next slide, please. This is France is showing the highest ever wave height. Germany has just finished its highest peak. Recently, it is going down in that wave. In Iran is also down, but Spain is going upswing. Italy is on the upswing, and Argentina is at the moderate level at the moment. Next slide. These are the top 7 countries in terms of cases newly reported in the last 7 days. Last 7 days, the world reported 48,54,000 cases, out of which United States reported 11,34,000 cases. UK reported 6,37,000. France reported 3,92,000. Germany reported 2,53,000. Spain reported 2,22,000. Italy reported 1,90,000, and Russian Federation reported 1,87,000. So this shows that it is concentrated in Europe. This wave is concentrated in Europe and also USA. Next slide. This shows the top 7 countries in terms of deaths newly reported in the last 7 days. 46,000 deaths were reported, out of which United States reported 9,277, Russian Federation 7,247, Poland 3,139, Germany 2,547, India 2,281, Ukraine 1,871, and Vietnam 1,635. So predominantly you're seeing Europe countries are reporting the highest number of deaths. In the last 24 hours, 8,000 deaths globally have been reported, out of which USA reported 2,194 and Russian Federation reported 1,002 deaths. Next slide, please. This is the map of the world with color coding according to the COVID-19 cases per 1 lakh population reported by countries, with the darkest brown being the highest concentration of COVID-19 cases per lakh population. And you find that is concentrated in Europe. Next slide, please. This is the map of the world with shading from green to dark blue. with COVID-19 deaths per 1 lakh population reported by the countries, and the darkest color you are seeing in terms of deaths, you are seeing in Eastern Europe. Next slide, please. The current global epidemiology of SARS-CoV-2 is characterized by a predominance of the Delta variant, a declining trend in the proportion of alpha, beta, and gamma variants, which have been circulating at a very low prevalence for several weeks, and the emergence of Omicron variant. Following the classification of Omicron as a variant of concern, many countries have adopted targeted sequencing strategies to detect the variant. The change in sampling strategy away from community-based surveillance sequencing may result in biases in the proportion of variants being reported. Thus, the recent declines in the proportion of Delta variant reported by some countries may reflect changes in sampling strategy, rather than declines in the proportion of Delta variant cases among all 19 COVID-19 cases. While most of the Omicron cases identified in November 2021 has now been reported in several countries. Of 10,51,598 sequences, 10,09,000, that is 96%, were Delta, and 1.6% were Omicron, and less than 0.1% were Gamma, and less than 0.1% were Alpha, less than 0.1% were Beta, and less than 0.1% comprise other circulating variants, including vaccine variants of interest, Mu, and Lambda. To note, global variants of concern distribution should be interpreted with due consideration of surveillance limitations, including differences in sequencing capacity. Recent evidence indicates that Omicron variant has a growth advantage over the Delta variant and is spreading rapidly, even in countries with documented community transmission and high levels of population immunity. It remains uncertain as to what extent the observed rapid growth rate can be attributed to immune evasion, intrinsic increased transmissibility, or a combination of both. There are still limited data on the clinical severity of Omicron hospitalization in the UK and South Africa continue to rise. And given rapidly increasing case numbers, it is possible that healthcare systems may become overwhelmed. Preliminary data suggest that there is a reduction in utilization of Omicron in those who have received a primary vaccination series or in those who have had prior SARS-CoV-2 infection, which may suggest a level of humoral immune evasion. As a result of this, the overall risk related to the new variant of concern, Omicron, remains very high. More information on this variant can be found in the updated technical brief and priority actions of member states that were published on 17 December 2021 by WHO. Next slide, please. This is the graph of the world where Alpha, Beta, Gamma, Delta, and Omicron have been shown how they are spread across the world. You see Delta and Omicron together. So it is now Delmicron pandemic globally. Sorry. At this juncture, I would again take you to a short video from Director General of the WHO, Dr. Tedros, talking about the current situation. Let's have a look at the video where Dr. Tedros is talking about his message on the day of Christmas. And it's important because Christmas is a beginning of the new year and end of 2021, and we're looking forward to 2022. Let's hear what Dr. Tedros has to say on Christmas.
2021 has been a painful year for many of us, but we cannot allow it to be a wasted year. As we approach a new year, we must all learn the painful lessons this year taught us. 2022 must be the end of the COVID-19 pandemic, but it must also be the beginning of something else, a new era of solidarity. We must leave 2021 behind with sorrow and look forward to 2022 in hope. On that note, I would like to wish all who celebrated a very Merry Christmas. Merry Christmas.
So, my friends, before I end, let's listen to the children in Africa on Christmas Day. 15 seconds, how we can be happy.
We wish you a Merry Christmas. We wish you a Merry Christmas and a Happy New Year. This is a season.
So, my friends, thank you for your attention. Thank you so much.
Thank you, sir. Thank you. And the video in the end was real hope. And with all the updates and the sorrows and the difficulties we faced in 2021, and the last was actually the video of hope. And as you told that we need to get up for vaccinations, especially focus on the rural areas. Thank you very much for the informative session and how we need to go about it. So shall we take the question and answers now? There is only one question actually in the chat box or in
As
the
you
end.
right, I'm here. As you are the moderator, you are the boss.
So there is one question in the chat box. It is your opinion about the booster dosages, and one question in addition to this from my side. What about the cocktail of vaccines, or we need to take the same vaccine as a booster? That will be better, or we can take any other booster, or can start all together with the new vaccine, which we have not taken.
Excellent, excellent. Both the questions are important. First, the boosters. As you had heard, WHO's opinion and Government of India's opinion is the same. Let's focus on completion of 2 doses to the entire population of India first and foremost. But booster doses have their place and time, but it has to wait little more time before the technical advisory group takes a considered view on the booster doses. If at all, booster doses would be required for a very small population, focused population, that is high-risk population, and also healthcare workers. High-risk population would be defined as per the age and their vulnerability to COVID-19 infection and their likelihood of hospitalization and deaths. That's part one. Regarding mixing of the vaccine, yes. First of all, we must understand we have 2 platforms working in India, Covishield and Covaxin. We do not have much more options at the moment. The Indian Council of Medical Research is recommending, and that is under consideration, that booster dose, if at all, will come up, will be people who have taken Covishield, they will require a Covaxin as a booster. And people who have taken Covaxin as a primary dose schedule, they will require booster with a Covishield. That is the current scientific thinking in all the studies that have occurred, and the results are available. But we should wait for final consensus to emerge. And there are a lot of other aspects involved. If you recollect, the volume or the production of Covishield is disproportionately higher than Covaxin. So if Government of India has to decide on a booster, they have to see the logistics part of it as well. So let's wait for the technical advisory group and Government of India taking a considered view on the boosters introduction sometime in January. Let's hold on till 2022 with the hope that it will start with a booster for healthcare workers and the vulnerable age group.
Thank you, sir. Thank you very much for this, hearing this query. I myself was having this query. Correct me if I'm wrong. So we need to change one more thing, focus on more on RT-PCRs than RATs. and that was something where we were lacking behind, and get up with the vaccines. So that is the take-home message from the current scenario.
Yes. I would reiterate, more than 70% of tests in any districts should occur with RT-PCR. And wherever the spread is occurring faster and the test positivity rate, even with rapid antigen test, is more than 5%, they need to have more than 80% test with RT-PCR. There are two reasons for it. You have more accurate and higher results, higher positivity rates, less of missing out individuals, number one. Two, with RT-PCR, you are also able to have suspicion of Omicron variant very easily because S gene is absent. So you are able to actually go for genomic analysis in a more rational and more, I would say, resource management way, because you will be able to detect and also put suspicious samples for confirmation of the Omicron variant. In that way, you will be able to contain the transmission more effectively by instituting not only detection, but tracking, surveillance, and also containment strategy.
Right. Thank you, sir, for clearing this thing. And I felt as if I'm again in my fellowship classroom listening to you. It's a privilege, seriously. And you are such a bundle of information. Thanks a lot.
Dr. Shiva, I feel he's raised his hand if you see on the.
Yeah.
Yes.
If you want to speak, yeah.
Yeah. Now, Dr. Rajiv Kumar, as usual, great. Now, I just wanted to make people know the clarification. Now, see, night curfew has been introduced, at least in Maharashtra, from today. Now, that night curfew is only section 144. You cannot meet more than 4 people outside. There is no restriction on people meeting in enclosed place. I don't know who has formed this rule, but it doesn't make any sense. On the daytime, you can have a market full, no problem. But at night, I don't know who has got the thinking that at 2 o'clock at night, 100 people are going to walk on the road. So this is a very silly thing. If at all, if you are enforcing, enforce with clarity, because the Omicron spreads in more enclosed spaces, not on open spaces. So that is what I wanted to clarify. Thank you.
Wonderful, Dr. Shiva. You have raised a very pertinent issue. There are 6 states in the country as now who have started with the night curfew. This is a debatable issue, how much it contributes to containment of transmission. Well, if you look at the COVID-19 Omicron situation in the country, the highest number of cases are in Maharashtra. Second is Delhi, and third is Kerala. And of course, there are 19 states in the country which have proven Omicron variant positivity. In addition, if you see, Kerala, as well as West Bengal, as well as Sikkim are having districts which have huge populations in the district where it is more positivity rates is more than 5%. The government of India is saying that the strategy should be multi-pronged and it should be district data-driven strategy, not the statewide strategy. Statewide strategy in Indian situation will not bear that much fruit as effectively as a district specific strategy. And the roadmap for containment strategy also has been laid down in the letter which was written last Tuesday by the Secretary of Health, Government of India, to all the chief secretaries of all the states in the country. So isolated knee-jerk reaction that you mentioned will not be effective. The spread of Omicron variant and transmission of Omicron variant will continue. As we have seen, community transmission, almost transmission which is happening in the community, which is not travel related, that is international travel related, has started in number of states in the country. That is the available data. So you rightly said, standalone night curfew will not work, except it raises issues of sensationalism, of raising issues of news headlines. But as far as epidemiology is concerned, it will be having very limited effect, if at all it will have any effect. Dr. Tyagaraja, Dr. Parul is raised his hand.
Yeah. Dr. Tyagaraja is raised his hand. So you want to speak?
Shall I talk, madam?
Yes, sir. Please.
Okay. Good evening, sir. To Dr. Rajiv Jain. Sir, I am in Goa attending orthopedic conference.
Great.
I
am aware of you posting some pictures.
Yes, sir. To listen to you, I have postponed my flight to tomorrow.
Great. I'm grateful.
Yeah, I do not want to miss any of DigiConnect platform clinical meetings. So today I wanted to postpone because I saw that it is in 25th. I thought Christmas there may be a gap, but anyhow, congratulations, sir. It is a wonderful this one. You have covered everything in the COVID-19, whatever we search, either we search with Dr. Anthony Fauci or with Tedros or with Maria, everything your encyclopedia has got. And we are very, very thankful to sir, you have said. And Dr. Shiva sir, what he said is really correct. In a daytime, it is a full of market. In night times, curfew. This is one of the most problem because see, even I met the president of occupation, this IOA. I asked him, sir, when the COVID is there, why you have this one? What he said is, doctor, I do not want to go in the history of IOA as a virtual president because that is my view. I have taken lot of risk, he said. So I didn't have any thing to talk to him. I said, sir, congratulations. May God bless you. And this is one of the most wonderful conference, sir. In Goa, I think yesterday we had a banquet. I think you will see one day in YouTube. And really, thank you very much, sir, for this one. Your lecture, one of the fantastic. Please continue, sir. You enlighten us about the COVID-19. Whatever you are really working hard and giving us all the information. What Mr. Anthony Fauci or Tedros or Maria or our chief scientist, whatever they give, you are summarizing everything and giving us. Thank you very much, sir.
Thank you, Dr. Tyagaraja, for sparing your time.
Thank you, sir. Thank you, Dr.
Thank you, madam. Thank you very much.
This is the beauty of DigiConnect, that we are connecting from Goa, Mysore, Delhi, everywhere.
And I recollect Parul as a AFIH student way back in 2018, and where ICMR South Zone Center, she was doing her AFIH, and for 3 days she was part of the participant for AFIH course. Very active participant, and of course, what she has done after acquiring AFIH qualification is wonderful. And I believe the organization she's working in will be very technical knowledge and interest and enthusiasm. And her debut today for DigiConnect webinar moderation, I congratulate her. Maybe we will have a moderation in the future also. Thank you.
Okay, moving forward to our second speaker, Dr. Ramanjeet. So yeah, am I audible? You're here?
Yeah, you are.
Okay. So I'll introduce Dr. Ramanjeet Singh. He has 14 years of experience in occupational health, well-being, resilience, and sports and emergency medicine. His focus to strengthen, sharpen, and sustain excellence in delivering integrated health management for industries and corporate groups for betterment of employees and organization and raising health standards. He completed his MBBS from GNC Amritsar in 2006 and got certified from ECFMG, USA, and did externships in USA. He has received many awards, certifications, and appreciations during his tenure in occupational and clinical health, like Best Doctor Awards at Fortis, Best Total Productive Maintenance for Clinic at Trident Industries. He's certified OSHA's 18001 2007 Occupational Health and Safety Management, and is medical and occupational health manager at Unilever Nabha. I welcome you, sir,
Thank you.
and we are waiting for your informative words on SIP, Systemic Investment Plan in Health. Over to you, sir.
So my slide is visible.
Yes, it is visible. Yes.
So, so we all are doctors, or maybe most of us are from the medical profession. So my idea is just to exchange a few of ideas. I mean, for the betterment of ourselves, for the betterment of society, for the betterment of our patients. As a medical professional, the more we exchange, the more we get, the more knowledgeable we become. So why I have chosen the word SIP? Because this is the end of the year. Most of us think about resolutions. So I believe we should think about resolutions for health as well. How to remain healthy. So I will not go into details much. I will try to remain crisp. I will try to talk about the crux of the slide which I have added. I'll not go into more about the text part of it. So as we know about financial investments, because we do consider it seriously, and most of us do, spend our investments into SIP, which is Systematic Investment Plan, in funds, right? So similarly, I believe we need to seriously consider investment into health by changing small habits, just small habits, which with time we should incorporate into our daily routine. And this is the way we can change, we can take our health to next level. This is what I believe. So when we talk about health, we talk about fitness, which actually means how efficiently we transport oxygen to the end organs. And nutrition should be mean how we sustain our glucose level. So if I talk about ages, 30 to 45, we all start working most busiest period of life. So many dependencies, job pressure, kids, social functions, gatherings. And this is, I think, this is a period which makes us more vulnerable to the diseases, especially the lifestyle diseases. Sitting is the next epidemic. We all know. Globally, we say sitting is equivalent to smoking, because it is actually. So when we enter into 50 to 60 years of age, those who get diseases, there is a risk of complication. We struggle, we get fearful, we delay our plans, we delay our tours, we invest some, our financial investment into health as well. We go to hospitals. Why? Because we did not consider SIP at appropriate time. What SIP? Financial SIP or health SIP? Financial SIP we do consider. Health SIP we rarely. We consider health SIP only when we get some shock, when we get some errors, when we get some issues with the reports. We do have, issues while considering financial SIPs. We struggle with budgets. We don't ask for experts. We do, have unnecessary expenses, some luxuries. But when we come to health, what are the obstacles we face? One of the most, what I feel is a discipline in life. Most of the people struggle in getting sleep on time. 11 p.m., 12 p.m., sometime 1 a.m. And this is the one thing where we need to be disciplined. Ideal time, I believe, is 10 p.m. 7 hours of sleep, 5 a.m., get up, then you have 3 hours of me time till 8 or maybe till 7, 2 hours of me time. That is a big time in a day. If you get up at 5, 2 hours, You can read book, you can go for a walk, you can go for a run, you can go to gym. So how to create 2 hours of me time is the discipline of life. If I talk about other obstacles, like when we have me time, we should not consider going online for Facebook, Insta, and many other things. That me time is not for the online. I believe unproductive time we should consider for these checking the social platforms. When we are getting ready, then we can listen to some audio, or many, I mean, when we are driving, we can put on Bluetooth, we can listen what's going on. One of the obstacles, I mean, for health sip is, for most of us, a day off or a leave or like a Christmas, we do consider going outside. We do consider heavy foods, going to marriages, busy schedule. This slide is very interesting. I mean, this somehow is related to more of mental health, but physical health as well. So the circle in the center is circle of control, which means how we manage ourselves, our energies, our meetings, communications. This is actually related to the discipline of life. If we control this, then we can control circle of influence as well. What is influence? What is circle of influence? It is somehow directly and indirectly affecting us, like policies which affect us, processes which affect us. Like if I change the exit time from the office is not now 5 p.m., it's 7 p.m. So it will affect us, definitely. But sometimes we consider the circle of concern, the outermost part, which we cannot control. That is totally out of control, but gives us anxiety, unnecessary anxiety. So this is the area we need to come out as soon as possible. Like we cannot do about the government policies. We have no control over it. Gas prices, but we do consider, it gives us anxiety. Another interesting slide. Most of our lives are run by unconscious and automatic actions, 95%. But what changes life is the 5% conscious and self-regulated actions. I would say if we from this 5%, if we change 1%, we can do a lot of changes into our health as well. So we usually see we divide health into physical, emotional, mental, and spiritual ones. Physical means how healthy, it is more related to diet, exercise, and sleep. We all know this. But this is the fundamental. If we cannot maintain physical energy, physical health, we cannot achieve what we want in emotional, mental, and spiritual health. Without physical, nothing is possible. Your mental, your emotional, and spiritual. Spiritual, spiritual means how we engage our spirit. What is the ultimate purpose of our life? What we want to achieve in our life. This is what spiritual energy is. So mental means it's not mental health only, it is how we engage in a day-to-day life. So fundamental is physical. I'll talk more about physical to only the interesting aspects. I'll not go into the textbook knowledge of it. So one of the physical 3 aspects, diet, exercise, and sleep. So let's talk about movement. So we all know movement is required for health. Movement gives a boost to heart rate, boost to blood circulation, but it gives boost to cognitive functions, hormones. Cognitive means it makes us mentally alert. A small walk after lunch rather than a tea or coffee gives you more alertness. This has been proven. This is 2 scans done by Harvard University. One is sitting quietly and after a walk of 20 minutes, look at the energy, the neuronal activity in the brain. It has enhanced so much. So that's why movement is necessary to remain healthy throughout the day. So what does that mean by throughout the day? I mean, we do 3 types of movements in a day-to-day life. We do small movements, we do major movements, we do stretching, right? Because movement has been proven to decrease so many diseases, as you can see this. So how we plan our movement? I mean, for doctors who does OPD like 2 hours continuous sitting, we have to find time with small excuses, going for a take print yourself, not telling someone to please bring that print. Just go and take the print. Rather than calling to a colleague in the nearby office or some other floor, just go and meet him. Just walk the talk. Getting water for yourself, going for a tea, not having tea on the desk. Maybe gamma off the plant, those who are in the manufacturing area, going to the shop floor and meeting colleagues. So these small excuses will make us active throughout the day. There's a recommendation as well. We should stretch and move small movements every 30 to 45 minutes and large movement every 2 hours. So we have to remind ourselves. There are many apps available. We can do this, obviously. So keep moving throughout the day, whole day. So this is one of the project with what I did with the stairs. So how we can change people behavior? We can change behavior. I mean, one of the thing is visuals. Visuals do affect the behavior. It may push you, it may force you to adopt that healthy behavior. That's why we have a strong, we have a strong trust on visuals. So this is the, a door of a lift or elevator. So this is the design we put in, I put in one industry. Stair climbing burns more calories per minute than jogging. Stair climbing burns more calories per minute than tennis. Push yourself, not the button. So some interesting punchy lines on the stairs as well. Models take the stairs to keep their legs toned for the catwalk. So there, this is one of the one step, uses 200 muscles. So this is a way we can tell people to adopt healthy behavior when you have two choices. One is stair and other is elevator. And you need to go to the third floor. We by default take elevator. Why not stair? Why not use our muscles? Going downstairs also burns different type of muscles. If we put such type of posters, we can change people behavior. And this behavior, once it's changed, we say it takes 21 days to build a new habit. If we build these type of small habits, we can burn maybe a few hundred calories extra per day. So change your life changing by changing one habit. So this is the SIP. Just think, have a round table discussion with your family that what dietary changes we need to maintain in our day-to-day life. What dietary changes, how to take out the, many sugary beverages out of the house, how to reduce when we go out for a meal with the family, why not we have half of the healthy choices and half of the want foods? So let's have a round table discussion with our family for the next year. Few more. Even WHO recommends 150 minutes of activity per week. So if we divide, it comes to 30 minutes per day. Or they also recommend mixing of activities. Maybe you can, we can do 2-3 days of aerobics, 1 day of yoga, 1 day of stretching, 1 day of gymming, 2 days of gymming, mix of activity. Very interesting aspect, epigenetics. So what is epigenetics? We know gene has two types of expression, genotypic and phenotypic. So science has proved that with exercise, we can make different proteins which are good, which are because of change in the phenotypic expression of the genes. This is called epigenetics, and it is transferred to the embryo, to the kids. So if a parents are active physically, their epigenetics is changed. The proteins which they make, they turn phenotypically to a good proteins. There is a less chances of diabetes in the kids as well. It reduces cancer risk, not in one generation to second generation, third generation as well, because the proteins now formed are good proteins. It has been proven for pancreatic cancer, prostatic cancer, and breast cancer. That's why we say activity and physical activity reduces cancer. It is epigenetics actually, and it has reduced lifestyle diseases also. So these are some interesting diagrams. Cycling changes phenotypic expression in the genes, obviously. On the lower side, you can see the fast food. It turns good proteins into bad proteins rather. So we all know insulin is very anabolic for gaining muscle tissue, but it is very anabolic for gaining fat as well. Both ways. Then how it happens? It happens the pattern we take our diets. If we take 3 major meals, we usually see a surge in the glucose long. If you see this diagram on the left, the green line is a glucose after the food. If after a major meal, the glucose rises so fast, similarly, the insulin rises so fast, then the most of the glucose is converted to fat. But if we maintain the plateau with smaller, frequent meals, the blood glucose level are sustained, and most of it builds insulin released helps into build into muscle cells. The more muscle mass, not the more fat. That's why we say let's take more frequent meals, small meals. We say not to be overfed, but to remain fed throughout the day. Overfed, over hungry, this is not the right way. So this is one pattern. We take pizza or major meal in India, maybe 3, 4, 5 chapatis some people take. This rise in glucose, then we take tea, then again one major meal. So this is the way insulin comes up fast and turns glucose into fat. On the other hand, if we sustain our glucose levels with small meals, small healthy snacks, we can build muscle cells, not the fat cells. Glycemic index, we all are aware of. This is what glycemic index is: sustaining a slow release of glucose from the intestine to maintain a plateau phase of glucose in the blood, not the surges, not the upstrokes or downstrokes. Some very interesting facts, you're gonna like this. So we all know we have around 5 liters of blood, and when we measure glucose, we say ideal range is 80, 90, 100 milligrams per 100 ml of blood. So this way, if we calculate, in 5 liters of blood, we have around 4 grams of sugar only, which means less than a teaspoonful. So in whole blood, we have 1 chammach of sugar, only 16 calories. And if someone is diagnosed as diabetes, which means FBS more than 120, 25, 26, he has 1¼ spoon of sugar. So difference of only half or less than half of sugar, the person is diabetic. So sugar is that dangerous to the blood or to the body? Half spoon sugar? Okay. It means the sugar is very carefully regulated in the blood. So if we eat extra, how much extra? For example, a person is eating at McD or some restaurant, 2 cheeseburgers, large fries, ketchup and Coke. This equals to 230 grams of carbohydrates, which is equivalent to 46 spoons of sugar putting into your body. So now you can realize we need 1 spoon. What body gonna do with extra 45 spoons of sugar? How it will affect the metabolism? How it will turn into a fat and disturbing the other important metabolic processes going in the cells. It will totally change the metabolism. Sugar is actually not required for our body, the simple sugars. The complex sugars also are required in limited amount. We all know this. But when we forget, when it comes to the taste. Some taste facts, if I talk, less crispy means more healthy. Do remember that. Why? Acrylamide is produced when sugar reacts with proteins on high temperature. And some countries has regulation on acrylamide levels in the food as well. Although smoky contains high level of acrylamide, foods do contain, but higher levels of acrylamide has proven cancerous in mice as well. The studies are going for human as well. So these are fries. I would suggest we should take, if someone wants to take fry, it should take at least less crispy. Even one interesting aspect, how to burn 100 calories in a day. Just walk for 35 minutes for a 70 kg person. And how to lose half kg per month. If someone wants to lose half kg per month, which means, so if I talk about 1 kg of body fat, it is equivalent to 7,700 calories, which means just burn 250 calories extra per day, then you will lose 1 kg per month. A simple calculation to remember. I want to lose 1 kg per month. I went to an expert and I told him I want to lose 1 kg per month. It means 7,700 calories, which means just burn 250 calories per day. Be consistent. Then you will lose 1 kg fat. So now we have to choose which bread we should take. if we were taking in the morning, more crispier, middle, or the less crispier. So we have to taste पे लगाम तो लगानी पड़ेगी थोड़ी. Sugar is definitely addictive. If we eat sugar, it produces addiction through dopamine. If there is an addiction, I mean, insulin, if you take sugar, insulin is released high, sugar goes down again, you feel more craving. So this cycle is repeated to those persons who eat a lot of sugar drinks and sugary substances. It is actually addiction. It takes time to reduce your sugar. It is not easy once you take high sugars. It takes time, 1 week, 2 weeks, 3 weeks. So slowly, you should reduce it. Like other addictions, you should not reduce it immediately. So what we eat, it actually how we look. Why I'm saying this? Skin replaces every 1 month. So if we take a lot of sugars, how metabolism is affected, how our skin will become, we can imagine. Blood cells in 4 months, whole skeleton in 3 months, and liver rebuilds in 6 weeks. So we are what we eat. It is actually right. If we eat a lot of food rich in antioxidants, vitamins and micronutrients, we'll be having a different ourselves in next few months. And few, tips. We all know trans fat in repeated cooking oil. We should avoid such foods. Let's make a resolution for 2020, 2022. No sugars, no refined sugars, no repeated heating stuff. Lot of bakery products, they contain the oil which they have reheated. Even the biscuits, the cakes which we get from outside. If we have craving, let's make at home. The other thing are samosas and many things. We all know this. Conclusion is we should eat frequently throughout the day. Use peace signs and meal. We all know 20 minutes concept. Our brain comes to know what we have eaten in 20 minutes. So when we are eating in front of the TV, we keep our brain busy in something else. So brain may take more time and we keep on eating. And sometimes we go to, marriage, we have a heavy meal. At that time we are okay, but after 20 minutes we feel, oh, I have eaten so much because brain takes 20 minutes. So let's stop eating when we are half done, 60% done. After 20 minutes, we will realize, oh, it's 100%. I did good. Let's not have a regret later on. Let's stop on a perfectly right time. Small habits which we can incorporate, which may be a part of SIP. One of the very important tasks which I take care, I tell my wife, I tell my parents, when we sit on a dining table or when we open our cupboard, the research says, there's one man, Brian Wensing, he has demonstrated you are three times more likely to eat the first thing you see in the cupboard. Whatever, if you're hungry, whatever comes to your hand, you put in the mouth. So rather than you will not look for the third, fourth, and fifth thing, which is lying behind. You will first eat what is visible to you when you are hungry. Then you will not look after the calories content, refined sugars. You just want to eat. That's it. You are hungry. So put the things which are healthier in front of you. First, front of the cupboard. Doing nothing else when you are eating. 20 minutes concept of TV. Remember, small habits will take time. 21 days. Give yourself 21 days. Involve your family. They should not tell it's enough, stop it now. It's been 10, 15 days. Tell them, give me 1 month. And small, like when we go to markets, offices, find a space which is away so that you walk more. It's not like that we have to complete 10,000. Why not 15,000? We struggle to complete 10,000, I understand. But these small habits, like parking away, going on a walk to find small things to get small things from the market, just have a half-kilometer walk. Taking stairs whenever you get chance. Second floor, third floor, fourth floor. You can go to 6th, 7th floor slowly. It takes time. If you have elevator and stairs both, just make up your mind. Up to 3rd floor, I will take stairs. Then I will take elevator if I need to go to 10th floor. And then every 3rd, 4th day, keep on adding level. Now I will go up to 4th floor. Then I will take elevator. If your office is at 10th floor. Next week, I will go up to 5th floor. Slowly, you will develop an endurance and stamina I can tell you people at the ages of 50, they can take stairs up to the 7th, 8th floor. Easy, just give yourself time and the conscious effort in your mind. The conscious effort matters. So sweet for taste, I always tell my patient, those even who are diabetic, first cut to half, then quarter, then say bye-bye sweets. This is required. Otherwise, if you say, no, you have to completely stop them, just discuss with them how to do it, practical ways. So recovery time doesn't mean mobile, going online. It may be deep reading, deep breathing, visualizing some of the good memories. It just gives you a relaxation. Calling a friend, a family roundtable discussion on health, how to reduce unhealthy habits in the family. We should discuss this. Always take a pause before consuming sweets and rethink, do I really need it or not? Now, the last message is tech snack. We all know this, but unconsciously, we keep on bending our necks while watching mobile. So this is a clear message. The cases of cervical spondylosis are increasing. So let's make a one habit. We can easily say when we bend our neck, the weight of neck on the cervical spine, the weight of head on the cervical spine keep on increasing, the more you bend. It can lead to nerve impingement, pains, spasms, and lot of problems in the early third. I mean, in the kids, I have seen having neck pains, but in now the cervical spondylosis is not a disease of 50s and 40s. It is a disease of 20s and 30s. The pains, the spasm. That's it. That's it from my side.
Thank you, Dr. Ramanjeet.
Just finding how to stop my
Thank
presentation.
you.
Pause here. Not very. Yeah. Thank you. Yeah.
Yeah. Thank you. So it's about SIP is all about physical, mental, social, spiritual, and financial health. So we all focus on financial health, but we forget to focus on physical health. Nowadays we take insurance and we just relax. we don't think that it's equally important to take care of your physical and mental health also. So I'll quickly take the questions. Somebody has raised their hand. Yeah. Dr. Shiva, you want to speak? You can unmute yourself and speak.
Yeah.
And then Dr. Gurunji. Yeah.
Yeah, Ramanjeet, excellent talk.
Thank you, sir.
I just wanted to bring two facts to people who are in the meeting. A study done about 5 years back on sedentary workers. Now, all of you know DVT is becoming more common. 38% of the DVT takes place among people who sit and work. This is very important because DVT can also lead to sudden death with pulmonary embolism.
Yeah.
Many of the sudden deaths are due to pulmonary embolism.
Absolutely.
Yeah. Second thing, all of you, especially all the people who are in the senior age group, must have seen that the policemen who were wearing half pant were wearing strappings in their calf muscles. The nurses who were wearing skirt were wearing stockings. The moment the pants became full, the skirt became sari, the strapping and the stockings disappeared. Without realizing that these strappings and stockings are to prevent varicose veins. I don't know why we don't think, because it is very important even today when you have long flights, 17 hours flight, economic class syndrome is becoming more and more common. So these are very important things which we should communicate to our employees. When I was in my organization, Siemens, all those who used to travel for more than 5 hours, have to wear stockings and go. Just a preventive measure. So that's what I wanted to add. Thank you for listening to me.
Thank you, Dr. Shiva. Thanks a lot. It's very informative, actually. How with the changing patterns, we forget what was it for. Yeah.
So actually, we obviously we all are doctors, but somehow as a human being, it is our nature that we forget the things. We struggle to incorporate small habits into our daily life. Despite knowing all the things, we struggle. So that's why I always focus on discipline of life. Discipline means getting on the bed on time. So that's you get your me time, whatever you want to do in your me time.
True, very true. Dr. Govinda, you want to speak? You can unmute yourself and speak. Your hand is raised.
Hello.
Yeah.
Sir, I just wanted to ask, you have just in one of the slides you have shown about the frequent eating. There are two ways actually. One is the frequent eating, other is the intermittent fasting. So what is your view about intermittent fasting also? I just wanted to know about intermittent fasting.
Okay, very good question. I believe we should do efforts which are sustainable first things, which we can do for long-term basis. Intermittent fasting are those for those who wants to lose the body fat fast and quick in 1 month or early. But when you stop it, if you are not aware how to sustain a good body weight throughout your life, you will regain your weight. So if you want to lose fast, you can do intermittent fasting. You can do find a lot of literature on the internet how to do properly do intermittent fasting, but you cannot do it for whole life. It is tough. I believe having a frequent interval meals, less of carb, and knowing how much we all suffer from protein requirement in a day. We need at least 1 gram per kg of protein. So just think, we take 80 grams, 70 grams, 60 grams protein per day? No, we take half or sometimes less than half. So everything is protein in our body. Antibodies. If we talk about COVID, antibodies, they're proteins. But if we don't take proteins, so frequent, I always trust. I mean, I'm not a very great follower of intermittent fasting. I believe in maintaining proper BMI throughout my life. And for that, I do efforts. This is my interest, what I have presented. It's my personal interest. This is not what I have read in MBBS, right? This is my personal interest. So intermittent fasting is for those who want to lose body fat fast, but not a sustainable effort. This is what I believe.
Thank you, sir. Thank you very much.
Rajiv, sir, you want to, Dr. Rajiv, sir?
Yeah, Dr. Ramanjeet, wonderful presentation, very simple and also very innovative title, which means, people are familiar with systematic investment plans in mutual funds, but they forget that systematic investment plan for health is more important, if not equally important than financial systematic investment plan. The one comment that I have is physiology is a subject which is taught in right from first year, human physiology. And when we practice occupational health and occupational medicine in organizations, it is the primary discipline which needs to be, honed every day. You having been taught sports medicine also, there again, human physiology is the primary discipline, and applied physiology becomes so important that we need to be, taught more structured aspect of human physiology. With the result, what is happening these days are people who are not experts in human physiology have become, kind of quacks, and many of the men and women as well, especially the younger age group, tend to fall back and they invest a lot of money on that without actually realizing the full potential of applied physiology on their long-term survival, especially middle age and old age. That was part of the comment. But the question that I have for you is, like, you're working in now in HUL Unilever, how HUL Unilever is actually applying these principles that you've talked about in the organization amongst its employees, and as a policy? That I would like to know more about that aspect.
So, Dr. Rajiv, there are two aspects. If I talk, this somehow comes under wellness and well-being. Most of the aspects of health other than occupational medicine and clinical medicine. So there are two driving factors in HUL. One are the global programs and one are the local programs. So local programs are totally in the hand of occupational health physician. That depends upon the health risk assessment we do on the basis of annual medical examination and the local health risk factors prevalent in the industry. Like if I say I have a more diabetic population, then I have to drive my health programs accordingly. So if I talk about global health programs, in most of the organization in MNCs, global health programs has a dual role of HR as well as global health leaders. So in HUL, we do have programs in detail. If I talk about physical health, there are online platforms where you can get trainings. There are webinars, there are talks on special days, and they do enforce sites to deliver those programs. There are monthly meets where we present ourselves what are the baseline statistics for the site or the baseline scoring for the site a year earlier. Now where we are, they enforce us to just see the, if I just give one example, we see the menu of the canteen. Then we divide our canteen menu into red, amber, and green. Then the target comes, can we change the red items into amber or green in next 1 year? What are the ER, employee relation, or HR, or the union challenges we are facing? So this is, we can take this one target. Like if I remember few years back when I was with Lexo, I changed bread pakoda into dalia. That was a demand of local as well as global program. And it was not easy. When the union, especially in Punjab, they want to eat bread pakoda, you were telling them to eat dalia. So it took a great effort. So there is always an enforcement to look after the canteen menu. People are watching you, you have to deliver in such areas. It's not at your will when you want to deliver. There is a structured, standardized programs for you. You deliver as well. And there are programs related to mindfulness, resilience, in every aspect of health. So they know what are the local challenges. You can customize those programs. You can tell them it's not possible to deliver mindfulness in Indian setup right now for mental health. There are many programs. You cannot deliver all. So you can always approach your leaders. Out of these 5 programs, these are practically possible 2 programs in my side. But this program I will take later on, not possible to take right now, or change the status or change some parameters for me.
Great. Thank you. Thank you.
One more hand was raised. Kaful raised his hand. Okay. So, Dr. Ramanjeet, it was more about what I feel from this talk is do more sustainable things than doing it immediately and then leaving it immediately. Like people, they just join some gym and all these things. They want to reduce immediately and there is no sustainability. It's better to have, a brisk walk or cycling like that. Same things apply to your diet things as well, which is practically possible, sustainable, then only it will work, right?
Absolutely right. Absolutely right. The one thing which I always tell my patients as well, the good habits like bad habits are also contagious. If you keep on walking, if you keep run, your wife will start, your kids will start, your colleague will start, your friend will start, everyone will start. So be a role model. As a doctor, we are not here to advise people, but we are here to lead by example. Whatever I do, I keep on my post, I do my story so that people, they see the doctor is doing, why cannot we? So it's a contagious. So do good things which are contagious.
And do whatever you do mindfully.
Obviously,
You should eat
mindfulness is a
mindfully.
great concept.
Yes.
It's just in one terms, mindfulness means जो कर रहे हो उसको enjoy करो, उसमें रहो. Involve your 5 senses into it. Taste it, smell it, feel it. That is mindfulness. It's not like that. Wife is sitting in front of you, you are on mobile or writing something, and at the end and you say, "Kya kaha aapne?" This is not mindfulness. It's disturb your relation. Mindfulness is a great thing. Multitasking is against mindfulness. Remember this.
So true. And there is again a very good concept you introduced. Give yourself 21 days. I also heard about this concept. Give your
Dr.
Am I
Parul, you're
audible?
mute. Yeah.
Am I
Some
audible?
disturbance was there. We heard you till 21 days. Yeah, you're right.
Yeah, I also heard about this thing that give yourself 21 days and you will definitely make the change.
Obviously.
So give yourself time, be considerate, be loving to yourself, and focus on your SIPs and health.
And make resolutions related to health. I request everyone for 2022, make resolutions for your health and take small steps. Do small steps in that, discuss with family, they will support you and achieve the target. Thank you.
Lead by example.
Lead by example.
For us.
For your patients,
For
for your
us, for
colleagues,
all the doctors.
everyone. Yes.
Yes. Thank you very much. Thank you very much, Dr. Ramanjeet. Any other question? Anybody wants to speak or ask anything? Nobody? Probably the lecture is also very well, delivered and explanatory, clearly explanatory. So thank you very much again. I thank both my speakers they have spared their time for us to enlighten us with such wonderful things. Thank you, Dr. Rajiv Kumar Jain Sarji, and thank you, Dr. Ramanjeet. Thanks a lot. So with this, we will end our session.
But before we end, Dr. Parul, we have to announce that this video, that recording is available, will be available on DigiConnect webinar platform on YouTube. This will be the 137th video on the YouTube channel DigiConnect webinar platform. And you can also watch 136 other videos on occupational health and environmental health, which have been recorded and are available for anybody on YouTube to watch and share in their own network. And again, I must thank Dr. Parul to accept our invitation for moderating this session. And it's been almost, it's 1 hour, 50 minutes session this has gone on. Thank you for your wonderful moderation.
Thanks a lot. So it's a privilege, seriously, to sit with you and attend all these things. Thank you very much, sir.
So Happy New Year, because this will be the last DigiConnect webinar for 2021. And we shall be meeting on 1st of January 2021, because that will be the Saturday. But before that, we'll have on Friday, the last day of the month, OCU Healthscapes, monthly video magazine on last Friday of the month. OCU Healthscapes would be at 6:30 p.m. on Friday at the same platform on Zoom.
Thanks a lot, sir. Thank you all the participants. And thanks a lot.